Today, we will review data about the relationship between the duration of untreated psychosis and longer-term prognosis amongst individuals affected by schizophrenia. The overall data seem to confirm what we might have suspected based upon clinical experience with other diseases, that the sooner that effective treatment is offered, the better will be the long-term outcomes. However, there are some nuances in these data that do deserve discussion. So in today's lecture, we will explore the origins of this idea of reduced duration of untreated psychosis. We will also explore the strength of the relationship between duration of untreated psychosis and longer-term outcomes. We will consider the mechanisms that have been proposed that might mediate this relationship between DUP and longer-term outcome. And finally, we'll briefly consider how this relationship has been messaged to clinicians and to the public at large, while also considering briefly the possible implications of this message for benefiting patients or for creating fear or harm. The idea that early detection of disease and early treatment of disease will lead to better outcomes is standard in medicine and is familiar to all practitioners. Regardless of the disease, in general, the longer that a pathological process is left unchecked, the more damage that process will do to the organism, the more complex the overall pathophysiology will become, and the more difficult the illness will become to treat. An important publication in 1991 by Richard Wyatt seemed to confirm this view. In Wyatt's paper, he considered many outcome studies from both the pre-medication era as well as outcome studies from the era of the first-generation antipsychotic medications. And Wyatt made several noteworthy observations, including that medication treatment was significantly more effective than psychotherapy or than social support, yet that outcomes in general were better when antipsychotic medication was combined with psychosocial therapies or other interventions focused on stress reduction. Wyatt also observed that early intervention appeared to reduce long-term morbidity, and he was primarily using rates of relapse or rehospitalization as his marker of outcome. To explain these findings, Wyatt raised the possibility that prolonged psychosis is somehow neurotoxic. He speculated that psychosis might be producing some kind of biochemical or cellular changes in the brain that predisposed the brain to continued psychotic episodes or rendered it less responsive to treatment. However, Wyatt was fairly at a loss to cite any robust physical evidence of neurotoxicity. Even though it was his favorite explanation, he himself admitted that the evidence of neurotoxicity was spotty. So altogether, the Wyatt study was the first major review article that brought attention to the relationship between duration of pre-treatment psychosis and the longer-term outcomes. So the Wyatt paper introduced the duration of untreated psychosis as a concept related to outcome and initiated a large number of studies that examined this possible relationship in greater detail. In the next several slides, we will look at three meta-analyses of this body of work. We'll start with this 2005 analysis by Max Marshall and colleagues from the UK. In their analysis, they found that there was initially relatively little correlation between initial duration of untreated psychosis and the severity of symptoms or functional capacity at the time of initial baseline assessment. However, significant relationships between duration of untreated psychosis and markers of illness expression and function did emerge at 6-month follow-up time points as well as at 12-month follow-up time points. The relationships still existed, but their strength weakened when they made observations at 24 months after the initial assessment. Although these relationships were statistically significant and consistent across numerous features of illness, they nonetheless had a small to modest effect size, with effect sizes generally hovering around 0.2, occasionally some facets going as high as 0.4. Nonetheless, 0.2 to 0.4 is judged as small to slightly moderate in the world of effect size interpretation. Next, here are the results of a meta-analysis from Penttilä and colleagues in Finland. They similarly found significant relationships between the duration of untreated psychosis and several outcome measures such as positive symptom severity, negative symptom severity, hospital utilization, social functioning, and employment. By every measure of outcome, the results were better for individuals with shorter durations of untreated psychosis. But again, as we saw in the Marshall studies, the effect sizes for these relationships were relatively modest. In this meta-analysis, we see effect sizes ranging from 0.1 to 0.2. So this would be regarded as a significant but small relationship. And here is another meta-analysis, this one by Nienke Boonstra and colleagues from the Netherlands. In this analysis, the beneficial effects of short duration of untreated psychosis became more apparent with longer and longer measurement intervals. So the benefits of early intervention became more obvious the longer a person lived or the longer a person was engaged in treatment. Nonetheless, even though these differences between short duration of untreated psychosis and long duration of untreated psychosis on outcomes were statistically significant, the magnitude of the effect was again relatively small, with effect sizes hovering around 0.2. So all of these meta-analytic observations tell the same story, that reducing the duration of untreated psychosis will enhance a person's likelihood for higher outcome, although the degree of enhancement may be small to moderate compared to standard care. In studies of the duration of untreated psychosis, almost all definitions of treatment refer to the initiation of antipsychotic medication. However, in this very intriguing Dutch study, De Haan and collaborators compared the effects of delaying the start of antipsychotic medication to the effects of delaying the initiation of intensive psychosocial treatment. And they found, intriguingly, a much more vigorous effect of delaying intensive psychosocial treatment compared to the effects of delaying antipsychotic medication. Longer delays to the initiation of psychosocial treatment were associated with a preponderance of negative symptoms of schizophrenia, as well as longer periods of illness during episodes of relapse. These findings, I believe, underscore the fact that schizophrenia affects multiple domains, and effective treatment should involve not just pharmacotherapy. And this study also further emphasizes that the importance of these non-pharmacological targets. Although the relationship between duration of untreated psychosis and longer-term outcomes can be very reliably observed, there is still no clear explanation as to what factors are responsible for mediating this relationship. The explanation that seems to get the most attention is a hypothesis dating back actually to Emil Kreplin's 19th century worldview that schizophrenic psychosis is inherently neurotoxic. Despite the pervasiveness of this hypothesis, which persists to 2018, neurotoxicity of psychosis has been difficult to convincingly demonstrate. There are several alternative and very logical explanations that don't invoke neurotoxicity to explain the relationship between protracted psychosis and poorer outcomes. These explanations posit that longer durations of psychosis ultimately affect the sufferer's personality or worldview in ways that make them less apt to engage with the world, and decreasing engagement with the world provides fewer opportunities to change ideas like people can't be trusted and I should detach from them. Related to these suggestions are that people who experience long durations of psychosis have difficulty in accomplishing important developmental milestones such as the completion of school, establishment of the work history, or the building of a supportive social network. In fact, some studies have shown that the process of psychosis results in a stripping away of a person's friendships and relationships, leaving the sufferer impoverished in this area. So these environmental, social, and psychological explanations also seem very relevant in explaining the negative impact of protracted psychosis on longer-term outcomes. Estimates of the actual duration of untreated psychosis in the United States suggest that many individuals are experiencing symptoms of psychosis for quite a long time before their initial treatment. Addington and colleagues looked at community mental health clinics throughout the United States and found an estimate of about 3.7 years for the average duration of untreated psychosis for the average community mental health clinic client. Note that the standard deviation about that estimate was substantial. The standard deviation extends to plus 5 years. So many individuals in the Addington study were experiencing durations of untreated psychosis for 8 or 9 years. Meanwhile, there is no clear answer as to what is the ideal shortness for duration of untreated psychosis. Several studies, though, attempt to address this question, again, mostly referencing meta-analytic data findings. And 3-month durations, 6-month durations, and 9-month durations have been proposed as the critical threshold. So although there is some variation in the estimate for the critical period, all 3 estimates have been less than 1 year. And I think the bottom line message is that shorter durations of illness are better, and that we have a long way to go toward realizing this goal in the United States. And so to summarize, there are obviously strong biological factors that cause schizophrenia and influence this course. Our knowledge of these factors is limited, and our ability to modify these factors is also limited. In other words, many things about schizophrenia are beyond our understanding and are out of our control. There are, fortunately, a number of social and environmental factors that do appear highly relevant to both causing schizophrenia and to affecting its course. And many of these environmental, psychological, or social factors, in fact, are amenable to modification. In modifying these variables, we can realistically offer our clients the opportunity to reduce the burden of their illness, and in some cases to help our clients to achieve very high levels of sustained recovery. So with this in mind, that there are some things we can modify, and we should make every effort to modify the things that we can, the relationship between duration of untreated psychosis and outcome becomes of great interest, because by shortening DUP, it's reasonable that at a population level we can have quite substantial impacts on public health. This probably explains the enthusiasm of national organizations such as the NIH to explore ways to reduce the duration of untreated psychosis and to keep the conversation of shortening duration of untreated psychosis at the top of our mind. So this is a laudable goal, and the messaging around it can be quite strong, and is not infrequently coupled with implied negative messages, and in some cases overt negative messages, that psychosis is a neurotoxic process and that individuals who have been ill for a long time are less likely to achieve good outcomes. These messages are poorly supported by available evidence, yet are nonetheless powerful enough to cause unnecessary fear or inspire hopelessness rather than hopefulness in the people that we're trying to reach out to and help. So we want to make sure that our discussion of this relationship doesn't disincentivize people that are perhaps ambivalent about seeking treatment. In all cases, and perhaps more importantly in cases where there have been longer durations of untreated psychosis, it's important to remember that good clinical practice for schizophrenia treatment involves paying attention to and addressing modifiable environmental, psychological, and social factors. And finally, if we're making efforts to try to get people engaged in treatment as early as possible, we should make every effort to ensure as often as possible that initial experiences of mental health care are pleasant, validating, and helpful. Shared decision-making is extremely important to this, as is designing treatments that place the client's goals as the centerpiece of treatment organization. You never get a second chance to make a good first impression, and we as a field should strive to keep that in mind and make every effort to eliminate involuntary treatment or aversive initial experiences of medication as somebody's first view of psychiatric care.